Welcome to NCLEX Clinical Judgment, Prioritization, Delegation, and Safe Decision-Making for Nurses. I'm Mary Jane Millionaire, a registered nurse, and I'm honored to be your guide through this practical learning journey. Whether you're preparing for the NCLEX, reviewing for nursing school, or strengthening your clinical judgment in practice, this audiobook is designed to help you think like a safe and confident nurse. Rather than memorizing answers, you'll learn how to recognize priorities, identify life-threatening situations, delegate safely, and make sound clinical decisions using evidence-based nursing principles. Each chapter builds the critical thinking skills needed to care for patients with confidence, both on the exam and in real clinical settings. I encourage you to listen actively, pause when needed, and reflect on the scenarios presented. The goal isn't simply to pass an exam, but to develop the clinical judgment that every competent nurse relies on every day. Let's begin our journey towards safer decisions, stronger critical thinking, and more confident nursing practice. This is NCLEX Clinical Judgment. Let's get started. Disclaimer: this audiobook is intended for educational and informational purposes only. It is not intended to replace clinical judgment, professional nursing education, institutional policies, or guidance from licensed healthcare providers. The content reflects general nursing principles related to prioritization, delegation, and clinical decision-making. Nursing practice varies by setting, institution, scope of practice, and jurisdiction. Readers are responsible for adhering to their facility's policies, procedures, and applicable laws and regulations. The author does not assume responsibility for errors, omissions, or outcomes related to the use or misuse of the information contained in this book. Clinical decisions should always be made based on individual patient conditions, professional standards, and collaboration with the healthcare team. By listening to this book, the listener acknowledges responsibility for their own clinical practice and decision-making. Section 1. Foundations of Nursing Thinking. Before a nurse can safely prioritize tasks or delegate care, they must understand how clinical judgment actually works. This section lays the groundwork for everything that follows by shifting the focus away from task lists and toward decision-making. Prioritization is not about speed, personality, or intuition alone. It is about recognizing patterns, identifying risk, and making deliberate choices under pressure. Many nurses are taught what to do, but not how to think when multiple demands compete for attention. This gap is where uncertainty, errors, and self-doubt often begin. The chapters in this section break down the core cognitive skills behind safe nursing practice. They challenge common myths, explain why memorization fails under stress, and reframe prioritization as a learned, repeatable process. Whether you are a new nurse building confidence or an experienced nurse refining judgment, these foundations are essential. By the end of this section, you will understand why prioritization feels difficult, how nurses develop clinical judgment over time, and how to begin thinking like a nurse, intentionally, safely, and with clarity. Chapter 1. What prioritization really means in nursing. Prioritization in nursing is often misunderstood. Many nurses believe it means moving faster, juggling multiple tasks at once, or trying to keep everyone satisfied. In reality, prioritization is the opposite of multitasking. It is the deliberate process of deciding what must be done first, what can safely wait, and what should not be done at all in a given moment. Prioritization versus multitasking. Multitasking suggests doing several things simultaneously. In nursing, this approach increases the risk of missed assessments, medication errors, and delayed interventions. The human brain does not truly multitask. It rapidly switches attention, which becomes dangerous when patient conditions change quickly. Prioritization, on the other hand, is sequential and intentional. It requires the nurse to pause, sometimes for only a few seconds, and determine which action has the greatest impact on patient safety. A nurse who prioritizes well may appear slower on the surface, but their care is more accurate, safer, and more effective. Why? Doing everything is unsafe nursing. The belief that a good nurse should be able to do it all is deeply ingrained in healthcare culture. This mindset leads to overextension, skipped reassessments, and failure to recognize deterioration early. No nurse can safely meet every demand at the same time, especially in high acuity or understaffed environments. Safe nursing care depends on selective attention. Choosing to address a life-threatening issue means something else must wait, and that is not neglect, it is clinical judgment. Nurses who attempt to meet every request equally often miss the one task that truly matters. The nurse as the final safety net. Nurses are the last line of defense between patients and harm. Orders may be delayed, incomplete, or inappropriate for the patient's current condition. Monitors may alarm incorrectly, or not at all. Other team members may not see subtle changes that occur between assessments. Because nurses are continuously present, they are uniquely positioned to notice early warning signs and intervene before deterioration occurs. Prioritization allows the nurse to focus on these critical moments rather than becoming consumed by routine tasks that do not immediately affect safety. Common myths that lead to errors. Several misconceptions interfere with effective prioritization. 1. Everything is urgent. When everything is treated as a priority, nothing truly is. 2. Fast nurses are better nurses. Speed without judgment increases risk. 3. Following orders equals safe care. Orders do not replace assessment and critical thinking. 4. Experience means you don't need a framework. Even experienced nurses rely on mental filters, often unconsciously. Understanding what prioritization truly means is the first step towards safer, more confident nursing practice. The next chapter will explore why memorization and rigid rules are not enough, and how clinical judgment develops over time. Chapter 2. Clinical Judgment versus Memorization. Many nurses are surprised when they miss prioritization questions, especially when they understand the disease process and know the right interventions. These errors are not a sign of poor knowledge. They occur because prioritization is not a memorization task. It is a clinical judgment skill that requires interpretation, comparison, and risk assessment. Why capable nurses miss priority questions? Priority questions, whether on exams or in real life, rarely ask what to do. They ask what to do first. Nurses often miss these questions because they focus on completing tasks instead of identifying risk. When multiple answers appear correct, the instinct is to choose the most familiar intervention rather than the safest or most urgent one. In practice, this same thinking leads nurses to focus on routine care while subtle deterioration goes unnoticed. Knowledge without judgment creates a false sense of competence. Clinical safety depends on the ability to rank problems, not just recognize them. Thinking like a nurse, not a test taker. Test takers look for keywords and memorized rules. Nurses look for threats to life, safety, and stability. While exams use structured formats, they are designed to test how a nurse would think at the bedside, not how well information was memorized. Thinking like a nurse means asking, who is at greatest risk right now? What change is unexpected? What problem will worsen if I delay? When these questions guide decision-making, both exam performance and real-world practice improve. Pattern recognition versus isolated facts. Experienced nurses often describe a gut feeling when something is wrong. This is not intuition, it is pattern recognition developed through repeated exposure. Over time, nurses learn to recognize clusters of signs that indicate instability, even when vital signs appear normal. Novice nurses, by contrast, often focus on isolated facts, a single lab value, a diagnosis, or a symptom taken out of context. Clinical judgment requires combining information, patient history, current presentation, trends, and response to treatment, into a meaningful picture. How experience changes judgment and how to safely shortcut it. Experience teaches nurses which findings matter most and which are expected. However, relying solely on years at the bedside is not always practical or safe. Structured frameworks, such as stability assessment, time sensitivity, and safety risk, allow nurses to borrow experience by applying proven mental filters. These shortcuts do not replace assessment or critical thinking. They organize it. By learning how experienced nurses prioritize, newer nurses can make safer decisions sooner, and experienced nurses can avoid complacency. Clinical judgment is not about knowing more facts. It is about using the right information at the right time. The next section introduces practical prioritization frameworks that turn this thinking into actionable decisions. Section 2. Prioritization frameworks. The core tools. Once nurses understand how clinical judgment works, the next step is learning how to apply it quickly and consistently. This section introduces the core prioritization frameworks that nurses rely on in both real clinical settings and NCLEX-style questions. Frameworks are not rigid rules. They are mental filters that help nurses sort through competing demands, recognize risk, and make safe decisions under pressure. When used correctly, they reduce cognitive overload and prevent decision paralysis, especially during busy shifts or high-stress situations. The chapters in this section focus on practical application rather than theory. You will learn when traditional tools like ABCs and Maslow are helpful, when they are insufficient, and how to combine multiple frameworks instead of relying on just one. Emphasis is placed on stability, time sensitivity, and safety, because those factors determine what truly matters in the moment. By the end of this section, you will have a set of repeatable tools you can use to prioritize patients, tasks, and interventions with clarity and confidence, even when everything feels urgent. Chapter 3. ABCs, Maslow, and What They Don't Tell You. Most nurses are introduced to prioritization through frameworks like ABCs and Maslow's hierarchy of needs. These tools are helpful, but they are often misunderstood and applied too rigidly. When used without context, they can actually lead nurses to unsafe decisions. This chapter clarifies what these frameworks are meant to do, what they do not account for, and how to use them correctly in real clinical situations. ABCs explained with real bedside examples. The ABCs airway, breathing, and circulation exist to identify immediate threats to life. When a patient's airway is compromised, breathing is inadequate, or circulation is unstable, nothing else takes priority. At the bedside, ABCs are not abstract concepts. They look like a patient with stridor after extubation, increasing work of breathing, a sudden drop in oxygen saturation, uncontrolled bleeding, or signs of shock. In these situations, interventions related to ABCs always take precedence over pain control, documentation, or routine medications. ABCs are most useful when a patient is acutely unstable or actively deteriorating. When ABCs do not come first. A common misconception is that ABCs apply to every prioritization decision. In reality, ABCs only guide care when there is a current or imminent threat to airway, breathing, or circulation. If two patients are stable, ABCs may not help determine who needs attention first. For example, a stable patient with controlled oxygen requirements does not automatically outrank another patient with signs of sepsis or a sudden change in mental status. In these cases, focusing only on ABCs can delay critical intervention. ABCs also do not replace assessment. A nurse must first determine whether an ABC problem truly exists or is expected and controlled. Maslow simplified for clinical decision-making. Maslow's hierarchy is often taught as a pyramid, but in practice it functions more as a priority lens. Physiological needs generally take precedence, but only when they are unmet or worsening. Psychosocial needs matter, but they rarely outweigh safety or physiological stability. For clinical use, Maslow can be simplified by, unstable physiological needs come first. Safety concerns follow closely. Comfort and psychosocial needs are addressed when stability is ensured. This approach prevents nurses from minimizing emotional needs while still maintaining patient safety. Combining frameworks instead of choosing one. Effective prioritization rarely relies on a single framework. Experienced nurses instinctively combine tools, ABCs to identify immediate threats, stability assessment to determine risk, and Maslow to guide overall care planning. Rather than asking, which framework should I use, nurses should ask, what is the greatest risk if I delay? This question naturally integrates multiple models into one decision-making process. ABCs and Maslow are starting points, not final answers. The next chapter introduces one of the fastest and most reliable filters nurses can use, distinguishing between stable and unstable patients. Chapter 4. Stable versus unstable, the fastest filter. When multiple patients or tasks compete for attention, the fastest and most reliable way to set priorities is to determine who is stable and who is unstable. This single filter often resolves confusion within seconds and prevents nurses from focusing on the wrong problem first. Stability is not about diagnoses or labels. It is about current risk. What unstable actually looks like. An unstable patient is one whose condition is changing, worsening, or at risk of becoming life-threatening without timely intervention. Instability may be obvious, such as respiratory distress or hypotension, or subtle, such as increasing confusion, restlessness, or declining urine output. Unstable patients often show trends rather than single abnormal values. A gradual drop in oxygen saturation, rising heart rate, or increasing pain can be more concerning than one isolated abnormal finding. Nurses must look beyond the numbers and assess the overall clinical picture. Acute versus chronic conditions. Acute problems almost always take priority over chronic ones. A patient with a sudden onset of chest pain, shortness of breath, or altered mental status is higher priority than a patient with a long-standing condition that is currently controlled. Chronic conditions become a priority only when there is an acute change. For example, a patient with chronic COPD who suddenly becomes increasingly dyspneic or confused may now be unstable. The key is not the diagnosis itself, but whether the patient's status has changed. Expected versus unexpected findings. Expected findings are those consistent with a patient's diagnosis, treatment plan, or recent procedure. Unexpected findings signal potential complications and require immediate attention. For instance, pain after surgery may be expected, but increasing abdominal distension or hypotension is not. Nurses should always ask, is this normal for this patient, at this time? Unexpected answers move the patient higher on the priority list. Red flags that immediately change priority. Certain signs should always prompt reassessment and escalation. Sudden changes in mental status. New or worsening respiratory distress. Uncontrolled bleeding. Signs of sepsis. Chest pain not relieved by rest or medication. These red flags override routine care and planned tasks. Recognizing them early allows nurses to intervene before deterioration becomes irreversible. Using stability as a primary filter helps nurses make rapid, defensible decisions. The next chapter builds on this by addressing another critical dimension of prioritization: time sensitivity. Chapter 5. Time-sensitive versus important tasks. One of the most common sources of stress in nursing is the feeling that everything is important. While many tasks do matter, not all of them require immediate action. Prioritization depends on distinguishing between what is time-sensitive and what is simply important. Life-threatening versus safety-threatening. Life-threatening problems require immediate intervention to prevent death or irreversible harm. These include airway compromise, severe respiratory distress, uncontrolled bleeding, shock, and acute neurologic changes. Safety-threatening issues may not be immediately fatal but can quickly cause harm if delayed. Examples include fall risks, hypoglycemia, medication errors, or failure to monitor a high-risk patient after an intervention. While these may not demand instant action, they must be addressed promptly to prevent escalation. Understanding this distinction helps nurses allocate attention appropriately without minimizing patient safety. Who can wait, and who cannot? Patients who are stable, receiving expected treatment, and showing no signs of deterioration can usually wait briefly, even if they are uncomfortable or requesting attention. Patients with changing conditions, high-risk therapies, or abnormal trends cannot. Waiting is not neglect when it is intentional and reassessed. Nurses should continually ask, what will happen if this is delayed? Will the patient be harmed? Will the condition worsen without intervention? If the answer is yes, the task becomes a priority. Consequences of delayed care. Delayed care does not always result in immediate harm, which is why it can be difficult to recognize its impact. However, missed reassessments, delayed antibiotics, or postponed escalation often contribute to preventable complications. Nurses play a critical role in preventing delays by recognizing which actions must occur within a specific time frame and advocating when barriers arise. Managing multiple, urgent demands. When several tasks appear urgent, nurses must compare risk rather than workload. Addressing the task with the highest potential for harm first is safer than attempting to manage all demands simultaneously. Clear communication, delegation, and reassessment are essential. Priorities change throughout a shift, and effective nurses adjust continuously rather than relying on a fixed plan. By separating urgency from importance, nurses can manage complex workloads more safely. The next section applies these frameworks to real clinical scenarios nurses face every day. Section 3. Prioritization in real clinical scenarios. Knowing prioritization frameworks is only useful if they can be applied in real time, under real pressure. This section moves beyond theory and focuses on how nurses actually prioritize in practice, when multiple patients, tasks, and interruptions compete for attention. Clinical scenarios rarely present themselves one problem at a time. Nurses must compare patients, reassess constantly, and shift priorities as conditions change. What was safe an hour ago may no longer be safe now. The chapters in this section reflect that reality. You will learn how to 1. Compare multiple patients quickly and logically. 2. Decide who to see first, second, and last. 3. Recognize when a stable situation is becoming unstable. 4. Adjust priorities mid-shift without losing control. These scenarios mirror everyday nursing environments rather than idealized textbook cases. The goal is not perfection, but safe, defensible decision-making that protects patients and supports nurses in high-demand settings. By the end of this section, prioritization will feel less like guesswork and more like a structured, repeatable process, one you can rely on even during the busiest shifts. Chapter 6. Prioritizing multiple patients. One of the most challenging skills in nursing is prioritizing more than one patient at a time. Unlike exam questions, real shifts do not pause between decisions. Nurses must constantly compare patients, anticipate risk, and adjust priorities as new information emerges. This chapter focuses on practical strategies for managing multiple patients safely and confidently. Comparing 4 patients at once. When faced with several patients, the goal is not to create a perfect order but to identify relative risk. Start by quickly assessing each patient's stability, acuity, and recent changes. Ask, who is unstable or trending toward instability? Who has acute or unexpected findings? Who is receiving high-risk treatments? This rapid comparison helps narrow focus to the patients who require immediate attention, rather than being distracted by routine or non-urgent tasks. Who to see first, second, and last. The patient who is unstable, deteriorating, or at highest risk is always seen first. The second priority is typically a patient who is stable but has time-sensitive needs, such as medications, procedures, or monitoring that cannot be delayed. Patients who are stable, predictable, and receiving routine care are seen last. This order may feel uncomfortable, especially when stable patients are vocal or demanding, but prioritization is based on safety, not satisfaction. Shift start prioritization. The beginning of a shift sets the tone for the entire day. Effective nurses start by scanning patient assignments for red flags, abnormal vital signs, recent changes, high-risk medications, or incomplete handoffs. A brief mental review of each patient allows the nurse to anticipate problems and plan care proactively, rather than reacting to crises later in the shift. Reprioritizing when conditions change. Priorities are never fixed. A patient who was stable at shift start may become unstable hours later. New lab results, medication responses, or subtle assessment changes can rapidly alter the order of care. Reprioritization is a sign of strong clinical judgment, not poor planning. Nurses who reassess frequently and adjust their focus protect patients more effectively than those who rigidly follow an initial plan. Mastering the ability to prioritize multiple patients is central to safe nursing practice. The next chapter applies this same thinking to medications, lab values, and procedures, areas where delayed decisions can have serious consequences. Chapter 7. Medications, Labs, and Procedures. Medications, laboratory results, and procedures often compete for a nurse's attention at the same time. While many of these tasks are routine, some carry significant risk if delayed or improperly monitored. Prioritization in this area requires nurses to distinguish between what is scheduled and what is safety critical. High-risk versus routine medications. High-risk medications demand closer attention because errors or delays can cause immediate harm. These include medications that affect airway, breathing, circulation, neurologic status, or blood glucose, as well as drugs with narrow therapeutic ranges. Routine medications, while important, are less likely to cause rapid deterioration if delayed briefly. Understanding this difference allows nurses to safely reorder tasks when unexpected situations arise. Before administering any medication, nurses must consider, is this medication time critical? What is the risk if administration is delayed? What assessments are required before and after giving it? Lab values that immediately change priorities. Not all abnormal lab results require urgent action. Trends, critical values, and unexpected findings are what shift priorities. A sudden change from baseline or a critical value indicating organ dysfunction, bleeding risk, or infection requires immediate assessment and escalation. Nurses should not view lab values in isolation. A result becomes urgent when it aligns with changes in patient condition or signals impending instability. Procedures that cannot be delayed. Some procedures are time-sensitive because delays increase the risk of complications. Examples include interventions related to airway management, bleeding control, sepsis treatment, or rapid diagnostic evaluation for acute conditions. When multiple procedures are ordered, nurses must assess which ones address immediate risk and which can be safely postponed. This decision often requires collaboration and advocacy. Monitoring and reassessment after interventions. Prioritization does not end once a task is completed. High-risk medications and procedures require ongoing monitoring to detect adverse effects or lack of response. Failure to reassess is a common cause of preventable harm. Effective nurses build reassessment into their workflow, ensuring that interventions have the intended effect and that emerging problems are identified early. By recognizing which medications, labs, and procedures demand immediate attention, and which allow flexibility, nurses can manage complex workloads more safely. The next chapter focuses on one of the most critical prioritization challenges, recognizing and responding to patient deterioration. Chapter 8. Deteriorating patients. Patient deterioration rarely happens without warning. In most cases, subtle changes appear hours before a crisis occurs. Nurses are often the first to notice these signs, making early recognition and timely action critical to patient safety. This chapter focuses on identifying deterioration early and responding decisively. Early warning signs nurses must not ignore. Deterioration often begins with changes that may seem minor or nonspecific. Increased restlessness, confusion, changes in pain patterns, decreased urine output, rising respiratory rate, or new oxygen requirements are frequently early indicators of decline. Trends matter more than isolated findings. A gradual change in vital signs or behavior can be more concerning than a single abnormal value. Nurses should trust changes from baseline, even when numbers remain within normal ranges. When and how to escalate care. Escalation is not a failure of nursing care, it is an essential component of safe practice. When assessment findings suggest worsening condition, nurses must communicate concerns clearly and promptly to the appropriate provider or team. Effective escalation includes concise reporting of what has changed, why it is concerning, what actions have already been taken. Delaying escalation in the hope that a condition will improve can lead to preventable harm. Rapid response versus continued monitoring. Rapid response teams exist to support nurses when patients show signs of acute deterioration. Calling a rapid response is appropriate when a patient meets criteria for instability or when the nurse has serious concern, even if objective data is limited. Continued monitoring may be appropriate when changes are mild, expected, or improving. However, nurses should err on the side of safety when unsure. Early intervention often prevents progression to a full emergency. Documentation during urgent situations. Accurate documentation during and after deterioration is essential. Nurses should focus first on patient care, then document objectively what was observed, actions taken, communications made, and patient responses. Clear documentation supports continuity of care and provides a record of clinical judgment and timely intervention. Recognizing and responding to deterioration is one of the most important nursing responsibilities. The next section shifts focus to delegation, another area where clinical judgment directly affects patient safety. Now that you've built a strong foundation in clinical judgment, it's time to put those principles into real nursing practice. In the remaining sections, you'll learn safe delegation, master NCLEX-style thinking, avoid common prioritization mistakes, use rapid clinical tools, and build the confidence to think like a competent nurse every shift. The first chapters introduce the foundations of clinical judgment, how to recognize priorities, identify life-threatening conditions, and make sound nursing decisions. Now, it's time to take those skills to the next level. In Section 4, you'll learn the principles of safe delegation, what can be delegated, what must never be delegated, and how the 5 rights of delegation help protect both patients and nurses. In Section 5, you'll uncover how NCLEX questions are designed. Instead of relying on memorization, you'll develop the critical thinking skills needed to analyze questions, eliminate distractors, and choose the safest answer with confidence. Section 6 explores the real-world mistakes nurses make when prioritizing care. Through practical examples, you'll recognize common pitfalls and strengthen the clinical judgment needed to make safer decisions under pressure. In Section 7, you'll gain access to rapid reference tools, high-yield clinical red flags, and prioritization checklists you can apply during exams and in everyday nursing practice. Finally, Section 8 focuses on building confidence as a nurse. Clinical judgment isn't about memorizing facts, it's about developing a safe, systematic way of thinking that guides every patient interaction. Whether you're preparing for the NCLEX, studying for nursing school, or sharpening your clinical skills, these chapters are designed to help you think clearly, act safely, and provide better patient care. If you'd like the complete guide for easy reference anytime, the ebook and printed paperback edition are now available on Amazon. Check the link in the description, and thank you for listening.